Psychiatry Grand Rounds at San Francisco General Hospital, where we are now having the fourth in our series on the history of public mental health in the modern era. We have had a presentation by Dr. Nye on the asylum movement, a presentation by Dave Ferriello on deinstitutionalization, and one by Dr. Quanbeck and Judge Anderson on assisted outpatient treatment. If you think about that, each of those represented a paradigm shift in the way we think about rights and responsibilities and divvying those up between the public sector and the patients that we treat. Each of those was really a new model of thinking about that. Today we have the fourth and culminating session in our series on the recovery model, which is really yet again another revision of how we divide up those rights and responsibilities. And I'm very much looking forward to our presentation and discussion. And for that, we have Ellen O'Donnell, who is a peer counselor, a KD certified drug and alcohol counselor, and a counselor with our very own Citywide case management program run out of our department. So, without any further delay, thanks, Ellen.
All right. Okay, here we go. Everybody. All right, so I wanted to start with a little bit of history of the recovery model, its origins. So in 1937, Abraham Lowe, a psychiatrist working in state mental hospitals in Illinois, founded a group called Recovery Incorporated. And his organization was devoted to structured self-help groups to provide aftercare for recently discharged hospital patients. And they focused on reducing relapses through social coping skills, goal setting, and increasing self-confidence. It set the template for the peer-led group model, which still exists today. Okay. Following that was the consumer survivor movement. After widespread closing of state mental hospitals in the 60s and 70s, consumers organized and proposed changes to mental health treatment. And a lot of that was in response to systemic abuses within the mental health system at that time. These included rights protection, self-determination, choice, peer-led services, and consumer inclusion in creating mental health systems and programs. Most recently, in the 1990s, professionals in the mental health and substance abuse fields began to adopt recovery-based treatment approaches. The 2000s saw the adoption of Proposition 63 in California. This led to an increase in consumers working in mental health, creating and leading treatment programs, and providing input into mental health policy. What is recovery? So the short version, and this is the most recent working definition from SAMHSA, is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. The long version from William Anthony, PhD, is recovery is a deeply personal, unique process of changing one's attitudes, values, feelings, goals, skills, and roles. It is a way of living a satisfying, hopeful, and contributing life, even with the limitations caused by illness. Recovery involves the development of new meaning and purpose in one's life as one grows beyond the catastrophic effects of mental illness. Okay. So now I'm going to explain a little bit about how the recovery model and medical model treatment approaches differ. So the medical model tends to define recovery in negative terms. Symptoms and complaints need to be eliminated. Illnesses need to be cured or removed. Patients need to be relieved of their symptoms and return to a pre-morbid, healthy, or more accurately, not ill state. Okay. I'm not going to bore you by reading all of these, don't worry. So to further illustrate this concept, I want to show a comparison of a person-centered and an illness-centered treatment approach. So I'll just read a few of these that I think are important. So in a person-centered approach, the relationship is the foundation. In an illness-centered approach, the diagnosis is the foundation. In a person-centered, services work toward quality of life goals. Illness-centered, services work toward illness reduction goals. And finally, person-centered approach, services end when the person manages their own life and attains meaningful roles. And illness-centered services end when the illness is cured. In general, a recovery-based, person-centered approach is more holistic. It looks at all aspects of a client's life, not only treating the mental illness. Okay. So now we're going to get a little interactive. So what do you all do every day to live a healthy and balanced life? How do you take care of yourself? What do you do every day? What's that?
Exercise.
Exercise?
I eat healthy except
Harm reduction. It's all right.
I sleep.
Sleep. Good sleep. That's a good one.
Take a shower in the morning.
Take a shower in the morning. So,
Go to work.
go to work. Yeah.
Yeah, don't say too long.
Exactly. Work-life balance. Exactly. So now I want to show you a comparison of how we define wellness for ourselves versus what we expect from clients. So, and this is just a generalization, clearly. So for clients, we would expect compliance with treatment. For ourselves, a life worth living. From clients, better judgment. For ourselves, a real job, career, financial independence. And finally, another example is for our clients, we expect active engagement and showing up. And for ourselves, we expect giving back and being needed. And I just want to be clear, like all of the clinical treatment things on the client side, those are all essential things too, but the other half, it needs to be the entire thing altogether. Okay, moving right along. Okay. Now I'm going to share with you a story of one client's story of recovery from mental illness and substance abuse. She has come a really long way in a really short period of time. And this is her story in her own words. So I came to Citywide in June 2011 at the age of 21 years old. I came here from the state hospital. When I got out of the state hospital, my goal was to earn my high school diploma, something that I did not have. I was struggling with self-harming behavior and was still in and out of PES.
I'm sorry, was still.
Huh?
Still what? In and out of PES?
In and out of PES. Sorry, I'll speak up. I could count a total of 6 times that I had harmed myself so badly to the point where I needed to undergo 14 hours of surgery. She used to swallow batteries. That was her main self-harming behavior. People did not have any expectancy I would make it, but I did. I was using methamphetamines off and on, and it made my mental health issues worsen. Now I have 15 months clean and sober, and I am happy. I have earned my high school diploma, and I am very active in my community. I have been offered employment, and I am currently enrolled in attending school. My life has changed, and I have transitioned to a lower level of care. And I just want to add, she hasn't done any self-harming behaviors in over a year. And some of you might be familiar. She said I could use her name. Her name is Meredith Hardesty.
It's great to hear.
Oh, familiar? Yeah.
You know her well.
We know her.
Yeah. Yeah, she's doing great. Okay. Okay. Now I'd like to share with you some of the guiding principles of the recovery model. It all starts with hope. Belief that recovery is real, visualizing how things can get better, and taking the steps to get there. And it's not only the hope that the clients hold for themselves, but as service providers, the hope we hold for them. Sometimes we need to hold the hope for them until they are able to have hope for themselves. And I think that's important because if we come into a relationship with a client and our expectations are very low and we don't think they're going to make it, that is going to transmit in the clinical relationship. Recovery is person-driven. Creating your own path in life, identifying goals, and making a plan for how to get there. The service provider works alongside the client and helps assist the client in achieving their goals, but is not, well, I should have put this, is not overly directive with the client. You do have to be directive with the client sometimes. That's just how it works. Okay. Recovery occurs via many pathways. In the medical model, there are specific criteria for what helps a person with mental illness recovery. There's heavy emphasis on compliance. Medication, therapy, and engagement in treatment is the measurement of whether someone is well or not. Engagement in treatment is also essential in the recovery model, but is only one piece of a larger picture. For example, with Meredith getting her GED, returning to school, and going back to work were all as essential to her recovery as medication and therapy. Recovery is holistic. Recovery encompasses an individual's whole life, including mind, body, spirit, and community. For example, self-care, medical and dental, spirituality, creative hobbies, etc. And again, these are all things all of us do to keep a balanced, well-rounded life. Recovery is supported by peers and allies. Peer-run support groups such as Depression Bipolar Support Alliance and treatment providers. Recovery is supported through relationship and social networks. Friends, family, peer support groups, spiritual communities, interest and hobby groups, and education. Through these relationships, people leave unhealthy and/or unfulfilling roles behind and engage in new roles. Friend, student, employee that lead to a greater sense of belonging, personhood, empowerment, autonomy, social inclusion, and community participation. Recovery is culturally based and influenced. Services should be culturally grounded, attuned, sensitive, congruent, and competent, as well as personalized to meet each individual's needs. Recovery is supported by addressing trauma. Trauma, substance abuse, and mental illness impact and reinforce each other in many ways. Service providers need to be skilled in providing gender-specific, trauma-informed services. So wow, that went much quicker than I thought. So I want to close by saying that both the standard medical model treatment and the recovery model, they're both essential parts of a client's recovery. One doesn't exclude the other. And I'm done way early, but all right. Yes?
You work for Citywide Case Management?
Yes.
Maybe you could tell us a little bit about that program and specifically what kind of services you offer, the types of clients that are the best match for your program, and how people make referrals and that kind of thing.
Okay. So Citywide is a full-service partnership. It's for clients that have a pretty severe level of impairment, and they have to be referred through CBHS.
when you say severe level of impairment, does that have to be a chronic psychiatric?
Chronic psychiatric, right. Most of our folks...
Who are demented or have brain damage or that kind of
most of our folks are schizophrenic, mood disorders, and lots of co-occurring substance abuse.
Okay, so those are the people that your program's really designed to
Right,
work with.
right.
Just to add that the supported employment and
Yes.
division is under Citywide, and the vocational rehab program is also under Citywide.
You mean the one here at the hospital?
Yes.
Yes.
So how have you guys been implementing the recovery model into your practice or your structure?
Okay, so we were part of a year-long learning collaborative called Advancing Recovery Practices, and it was a statewide collaborative with many treatment agencies, and it was all about finding treatment approaches based in the recovery model. Like a really good example is the strengths assessment, which you sit down with the client and pretty much like you talk about what their goals are now, what has worked for them in the past, and what are the first steps that they're trying to do to get there. And we also implemented that approach as part of our case presentations instead of just the standard case presentation format. And it was really great because, I mean, a lot of case managers said that they saw their client in a whole new light, that, you know, they had strengths and abilities that they don't think they would have found doing a standard presentation. Yes?
Considering you're familiar with our sort of very acute short stay
Yes.
here, how would, and this might be a really packed question, how would you suggest for your clients, because many of them, you know, get admitted here, or from here we admit them to you, how would you suggest we continue the recovery model for a short time that are patients in the hospital here in a crisis? What kinds of things would we focus on? And for someone that's in your program already and just having a bit of a setback?
Oh boy.
Do you think we could be successful in that, in continuing that, or helping people focus on that in the little bit of time that they're here?
I think so. I mean, what I'm thinking about is a lot of the times when people are inpatient, their needs, their basic needs are so great. Like, you know, they don't have housing when they get out of here, all sorts of other things that are going on. But I think a way to implement recovery would be to talk about, like, what are your goals? What are your hopes for yourself? What are some really small steps that you could take when you get out to start moving towards that? Who can help you? Your case manager, other people in your life. I mean, I think especially when someone is inpatient, because they're, by that, when you're in crisis, your hope is really, really low for your life. So it's really important to instill that. Did that answer your question?
Yes, actually.
Okay. Yes. Hi.
How are you?
Hi.
I just was going to piggyback on that a little bit, since I've sort of done both now because I'm working here inpatient, that I think that, like, there's sometimes, and tell me if you agree about this, but there's sometimes I think that with how short a stay that we have with patients inpatient, that it's actually kind of, to me, feels sometimes very inherently recovery oriented, because we have to rely on the tools of patient strengths to offer them anything, because there are so few resources. And so, like, making some of the interventions that we do with them here inpatient be really oriented towards putting them in the driver's seat and relying on their strengths is kind of something we have to do, since we don't have as much to offer them as maybe we did in the past.
Right.
I don't know if that feels the same from an outpatient perspective when you see us discharging people or not, but.
No, absolutely. All right.
Renee, you can probably speak to this better, but one thing we've started in an OT also is kind of a adapted and very loose adaptation of the RAP program, which I'm sure you're familiar with, and it's not really appropriate for inpatient, but so I don't know, Renee, if you can speak to what Joyce has done with it, but I think that it goes in line. Mm-hmm.
So we're working on making a packet that patients can fill out when they're here that really focuses on what resources they have in the community, what things were helpful for them in the past, and it's something they can fill out and take with them. Also focuses on strength and nothing, it's very recovery language oriented, so there's nothing about necessarily their diagnosis or it's not medical model.
Right.
So it's talking about strengths and resources, and then very focused on their own goals, what they would like to accomplish and what they can do to be successful right when they leave the hospital.
That's great, just spelling it all out. I mean, especially when someone's in crisis, it can be hard to think about what you do have that can help you. Yes.
So I think most of us, when we hear the term, recovery or recovery program, we think about substance abuse treatment. So could you say a bit about what is the relationship between your recovery model and the typical 12-step programs that are out there in the community, and what might be some of the differences?
So,
I mean,
there are
the 12-step model?
Our program is harm reduction. Okay. If clients are abstinent, we absolutely support them in that, and we do have some abstinence-based groups at our clinic. I think there are a lot of parallels. I think maybe, just off the top of my head, a difference in the recovery model is, and 12-step, in the recovery model, where your recovery is self-defined. It doesn't necessarily mean like someone's like completely cleaned up, they've got a full-time job, an apartment, and the whole shebang. Recovery model can be like someone's not sharing needles anymore and someone's reduced their hospitalizations. That can be their measurement of recovery. However, in the 12-step model, the measure of recovery is abstinence, and there's not a lot of wiggle room. Does that answer your question partially?
No.
Okay.
Yeah. So basically, your work is more harm reduction, which is not true of 12-step programs.
Right.
Well, I just want to add to that too, that I think that it's sort of a misnomer. They're two really different things. They just use the same word, and that the recovery movement is really focused on the idea that people can absolutely recover and consider themselves recovered from their mental illness, from the symptoms that they find troubling. And the 12-step model is very focused on people identifying as always having that disease. And I find that to be a really important distinction between them, because that is a very different model than the recovery model.
Right.
It's really saying, like, when you have achieved the goal of what you would like your life to look like, you are recovered from your mental health diagnosis as identifying yourself as that sort of patient. And it's sort of a semantic difference, but feels like an important one.
Isn't it more than semantic? I mean, it takes
it is.
I'm an alcoholic to going, actually, there's a piece of my life where I deal with alcohol, but I'm also a father, I'm a husband, I'm a nurse. Like, it's more than just semantics. It's saying you're not your diagnosis, right? It pulls you away from this concept of I just have to spend the rest of my life running from or dodging this bullet instead of going, it's a piece that I have to be concerned about, but it's managed within a small, in this big sphere of things, and that it puts it in perspective, because that's the shift from the medical model, which is, while you're here, we got to deal with this crisis, to move it away from a crisis to this sustainable, long-term, kind of like healthy, like I can do this long-term instead of getting through the next 2 weeks as a schizophrenic, or having schizophrenia, or hearing voices versus I'm schizophrenic for the rest of my life.
Right. Yes. I would just add that I think the 12-step model, it's more, they also accept the things, that the parts that you identify as an alcoholic, and there's no shame in being an alcoholic, and knowing that you're an alcoholic is what gives you the strength and the knowledge to, live a life, however you choose. But I think that they have in common is that they're both very hope-based. In the old days, if you're an alcoholic, your life was ruined. You were hopeless. There was no hope for you. But I think, for example, 12-step models are like, oh yeah, you can be an alcoholic and you can have an amazing life. You can have, whatever your dreams are, you can have that too. And I think that's the same thing with this. They're two totally different. They're kind of different things. But this recovery model is that you're not your diagnosis.
Right.
And you can go on to have a great life. It's not your destiny. It doesn't mean your life's going to be ruined,
And one thing you just brought up is like a big similarity. It's both are based in peers helping peers, people who are going through the same struggle.
I have a question that actually piggybacks right onto that. I was going to ask if you would maybe explain a little bit more for some people, like what your role is as a peer counselor for people that maybe haven't had as much experience with that, and what sort of context you think you see those services being most useful.
Okay. Well, I do a lot of stuff there. Let's see, I do a couple groups. I do a harm reduction group. I do a healthy relationship group. I did a group on community integration for a while, which is really, really challenging. Our folks do not want to integrate into the community, is what I've found. And it is really hard because there's a lot of stigma, and a lot of places in the world our clients aren't welcomed with open arms. One thing I've done is I had, as part of the learning collaborative that I was part of, I wrote some bullet points about my own recovery story, and I shared them with new clients as they were coming in. And the feedback I got from clients and from their case managers is that their hope increased in hearing my story of recovery, because I have not just mental health diagnosis, but also recovery from substance abuse. So we could definitely connect a lot. Did you want to know more?
Oh, no, I was...
Okay.
The only other follow-up to that was, do you think, what other context do you think, I mean, I know at Citywide is an example, but I don't know if you've seen it, peer counseling in general, being used in specific contexts, but if there's other contexts in which you think that's helpful. It seems like it's an important part of the recovery model.
Well, the field of the peer counselors, it's changing a lot. Back in the day, it used to be just, come to the clinic and just share your recovery story with folks. And that was your main function, or you took them to the DMV, and that was the extent of your role. But it's changing a lot. They're looking at having a national certification for peer counseling. And for example, in my role, I started out just doing a couple groups, not much, taking clients to the DMV. But in the past 4 years, I've learned the harm reduction model through doing the STOP group. And I've given presentations at Grand Rounds, and I took part in a year-long learning collaborative. I learned about benefits counseling, which is teaching clients about how to work while getting SSI and SSDI. And I've just learned so much and grown so much through the past 4 years working at Citywide. But my position is not representative of every peer counselor in the field.
We've had peer counselors here on inpatient psychiatry. Do we have one now?
I mean, you should ask. So my program, with the profits that we've made over the last 3 years, we've actually made enough money to hire 2 out of the profits. So we've got Eric down at the hot dog cart, and then we've got somebody that we're hiring for our kitchen, and those are the profit ones. And then we've got 2 more that we're creating from the old position. So we're actually going to have 4 peer counselors in this program.
That's great.
And since I have the floor, I just want to say Ellen and what she brings to our program is amazing, because people are so afraid to work because of fear of losing their benefits. It's the greatest, I think, barrier to getting people back to work. And Ellen is our resident benefits counselor, and she is absolutely amazing at it. And it really breaks down so many barriers for people to know that they're not going to lose any money by working, and it's not what they think is going to happen. So just know that.
Thanks, Mindy. Yes.
One of the things that 12-step programs and recovery clearly share is that they're both lacking an expert on the white coat who has the received collection of knowledge and passes it out in a sort of a one-directional way. Do you have any thoughts about why that makes things work differently or better for some things in the medical model?
Okay. Do you mean that it's not like evidence-based and?
No, just that it's the personal relationship in it is different. There's not a power relationship with some authority figure, some expert who's making decisions for you.
Well, I think a big difference in both is that the people working with each other, I mean, people may be at different points in their recovery, but people are meeting on a pretty equal playing field. And also that, you know, like especially a good example of this is like the sponsorship that happens in AA. Somebody who has like a lot of clean time, a lot of experience in coping with sobriety, and they can impart that to someone else. Did I answer your question?
Yeah.
Okay.
You know, sitting in meetings with our peers, I'm so blown away by the value they bring to working with our clientele. So many things that they know about drugs, using, I mean, just things that I really, you could hit me on the head with something and I wouldn't know what it was. And I'm such a fan now because they bring so much to our meetings when we're talking about, you know, our clients and what's happening with them. And they're like, this guy's using it. And I'm like, really? How do you know? And little things, they have a nuance that we don't have because
right.
they've been through it. So I'm really a big fan of computers working for our program.
When you've been there and done that, you know it when you see it. Yeah. Yes.
Well, I'm finding this really interesting because I think I kind of walked in here thinking recovery model, and when you started talking, I was thinking, well, recovery as in cures. And you're not talking at all in the same, I mean, I know people in AA or you know, any of the substance abuse 12 steps will say, you know, I'm not cured. This is always something that, as Mylene, you said, you have to kind of watch out for and be aware of. But it seems so much more of what you're saying is you define for yourself what your recovery is. Maybe you just don't run away from voices, or maybe
right.
You know, it's whatever you define, but it doesn't mean that your illness disappears. It's how you might cope with an illness.
Right.
And move forward in a hopeful way, making your own goals.
Right.
So that's a real eye-opener for me.
Thanks.
Another thought.
Yes.
Kind of piggyback off Dr. Rouse's question is, I think maybe something that we can think about as an inpatient team is the language we use. I mean, I know that's already been mentioned, but to sort of bridge that gap between professionals and medical staff versus peers or peer counselors and patients. The way we talk about certain things in certain language we use, I don't know if you have any insight on that, but it seems like that could maybe help bridge that gap. I know in my experience being I'm one of the occupational therapists, so we often have a different relationship with the patients than, say, the doctors or the nurses, because we're not giving the medication, we're not the ones serving the 5150s, forcing them to do anything they don't want to do, which obviously can't be avoided from some of the medical staff, but it seems to me that maybe we can incorporate some of this language and focus more on strengths and goals and talking to people with a different kind of approach, and that might be helpful.
Definitely. I mean, one of my pet peeves that came directly to mind when you said that was saying, for example, she has schizophrenia instead of person with mental illness. That makes me, I hate saying makes me crazy in this context, but it does. Yeah.
Could you say anything about, along the same lines, about the thing of being non-compliant with meds? That's something that we put in charts all the time, I think daily. It's like if someone's not taking their meds, they say non-compliant with meds. And that's something I know there's a reframe for that, as well as someone is, can you speak to that a little bit?
Not an expert in that, but I think non-compliant is non-compliant.
The client's choosing not to take their medications.
Right.
You know, that would be a reframe of, rather than saying they're not compliant. It's sort of like a nuance thing, from what I understand.
Right. Right.
Many people say adherent.
Yeah.
You know, I can say that our peers will talk to them. I mean, for one of my peers to go and know somebody's non-compliant and say to them, listen, this is what happened to me. You know?
Right.
It's so different than me saying, dude, take your medicine. You know what I mean? So
right.
That's where I'm seeing this being such a wonderful model.
Right. And that was definitely one of my key points when I did the peer one-on-one showing my recovery story with clients, because I spent a whole lot of years on and off meds, and it's all tied into stigma of like, oh, I got this, you know, it's not a problem, because I think this is true of a lot of people heavily associated being on psych meds with admitting that I had a disability.
Plus, I mean, isn't inherent in the phrase med compliant is, you know, I have this authority and you're not complying with what I request. So it's very, as Dr. Ralph put it earlier, there's an authoritative position and then there's a subservient position. And that's, you know, it's not empowering, right? The point of recovery is to empower, and you and me, as if we're taking care of someone, we can't really empower someone, right? Empowerment has to come from within. And when we say med compliant, it means I have authority, I have the knowledge and the power to make you better. And I think we do have the ability to help them move away from crisis, but to actually recover requires this kind of like, you know, indwelling, self-generated thing that compliance, it actually takes away the power from a person, right?